just get back to the beginning. Okay, well, welcome everyone. We've got no public questions, I'm informed, so we'll move straight on to the business. Apologies?
No apologies.
Thank you. Any declarations of any other business or declarations in the register or the agenda? Nope. Okay. Minutes of the meeting on the 13th of April at 5.1a. Any corrections, please? David.
One of the paragraphs is accurate, but doesn't quite reflect what I was trying to say. So I'll just work with Julie on that, if that's okay.
So it's a sort of quite a subtle amendment, is it? Rather than...
it doesn't significantly alter.
Okay.
Alter the minutes, no. I was talking about pathways rather than ICS structures. You know.
Okay. Well, I'm sure Julie will modify it accordingly.
Thank you.
Action log and matters arising. I don't think there's anything that isn't already done or in hand. There's nothing seems to be late unless anyone's picked something up. No. Okay. So let's move on to the quality section. Item 6, a patient story, children's speech and language therapy stories. So Debbie, over to you.
Yes, thank you. Rachel is here and online, who is going to do this presentation for us, because she will be able to talk firsthand. It's a story that she's been involved in. So I'm going to hand swiftly over to Rachel for us.
All right, Rachel, welcome.
Thank you. Good morning, everyone. I'm just going to share a slide screen, if I can. There we go. Hopefully everyone will be able to see this coming up. Everybody?
Yes, thanks, Rachel.
Got that, okay.
Yeah.
All right, so good morning. I'm a member of the speech and language therapy team, which forms part of the dysphagia service. So we are provided by SIPIT, Speech and Language Therapy, and we form part of the services that form part of the Dingley Child Development Centre. So that's contracted with the Royal Berkshire Hospital. So we're sort of a little bit between the two. But we have counterparts in the East who do the same sort of job, but they don't see infants. They see children from 6 months of age, whereas we go down to infants because we cover the paediatric wards as well. So the SLT role is to assess the physical safety and development of the baby or child's ability to eat and drink. So we do that, but taking into account lots of factors and work collaboratively within the team. So hopefully this case study will give you a flavour of that. This can involve alternative feeding alongside oral feeding, so breast, bottle feeding, advice regarding positioning, looking at the developmental stage of feeding and the oromotor skills, so your articulators, but they're involved in feeding to start with, so tongue, lips, jaw, teeth, palate. Looking at appropriate bottles or teats for successful feeding, strategies for pacing the feeds or consideration of early weaning, all with the aim to promote safe oral feeding where possible to sustain that child's growth and development. And we also have a video fluoroscopy assessment service available at the Royal Berks, which is a moving X-ray of the baby's child or swallow. And these are run jointly with radiology where we need to. So hopefully that just gives you an idea of our service. And the case study I've brought is a little baby who has a syndrome. I didn't name it because I wasn't sure in terms of where these go out. I didn't want the child to be identifiable. So this is a particular syndrome. And this child was referred by the paediatrician at 16 weeks. And the baby was also referred to OT, the occupational therapy service, in specialist seating, because part of this syndrome is the baby can have quite low tone. So the history of feeding difficulty and faltering growth, so not growing so well. Key factors really were that the baby had low tone, there's a heart issue, pulmonary stenosis, which is a narrowing of the airway, a tongue tie, reflux with vomiting, so where the milk's tracking back up, Possible cow's milk allergy. So there's quite a lot of factors. Health visitor was supporting at home with feeding, liaising with the medical team at Royal Berks at the time of referral. So I made a visit to the baby, who's 17 weeks at this stage, home with the parents, and felt that baby was safe with swallowing in terms of aspiration. He wasn't taking, milk into the lungs and, could cause chest issues. But, low tone was having an effect on feeding, positioning for feeding, being stable to be fed. And also he had quite a marked anterior and posterior tongue tie. And it's mainly anecdotal evidence about that, but that if this tongue tie can affect the peristaltic movement of the tongue, and it can cause issues with aerophagia, which is sort of swallowing air really, and cause problems and make the reflux worse. So I felt that I could give advice on pacing and positioning for feeds, but also I felt that I fed back that I felt the tongue tie release would be advised. But there's an issue with clotting with this syndrome, so they had to seek further advice before they could proceed with any kind of release. So baby sort of continued to be fussy around feeding with vomiting, and there's issues with winding him, which is probably linked to his low tone. So it's quite difficult going forward. Unfortunately then, baby was showing faltering growth and not feeding well. So there was an admission with some reflux medication trialled and alternative milks around the cow's milk, but didn't really make very much difference. They passed an NG tube, and he was seen on the ward then by our service, and we advised an alternate NG feeds and oral feeding. So the baby's very sort of tired, fatigued by this point. So he was discharged then with the NG tube in situ and a high calorie milk prescribed. So he then became involved with the community nursing team and paediatric dietitian because he'd had a tube passed and been returned home with his parents administering feeds. And they carried on doing the NG and the oral feeding. They discussed the tongue tie again in the wider team and decided that this could go ahead. So that was released when he was 22 weeks, and it was an anterior and posterior tongue tie, so that release was successful. So I then was involved to reassess the physical skills for the swallowing with a dietitian at 5 days post tongue tie release, and the baby was feeding better. He wasn't taking reflux medication anymore. They had disbanded that for the time. So I'd been in touch with mum prior to this around the teats she was using, because she was trying to manage with sterilising single-use teats that she had from the hospital. So I took out an appropriate teat, which was the same sort of shape and a slow flow. So mum was able to use the one that we had available and then order some more for the baby so that he could feed successfully, and that was what happened. I also looked at the chair and the seating due to the low tone and the support that's going to be needed going forward. So the family is still awaiting a specialist chair, but we potentially, in issues where you've got reflux and so on, you might look to wean early to aid the weight gain and reduce reflux issues. So, and the consultant we'd liaised with had previously given the go ahead. So the dietitian made a feed plan at this visit, taking into account what he was managing orally and with an aim to wean off this NG tube. So this was sort of ongoing support for the family at that point. I'd made a link with another local family who have a child with this syndrome who also had early feeding difficulties. And mum has spoken to and exchanged some texts with this mum, which she found helpful. So that was support there. And the health visitor has been closely involved, and the community nurse continued to make regular checks with the parents to support the NG tube use, and also support for maternal well-being, because there's a diagnosis that parents are coming to terms with. And the dietitian has continued to check in with the family for weight information and about progress to oral feeding. So, sorry, it's a bit small, I'm aware. So made another further joint appointment. The dietitian was updating the team, and the baby was able to transition onto the oral feeds, which was great, and no longer use the NG tube. The syndrome is associated with restricted growth, but now on the 0.4 centile for the first time, which is encouraging. And did a joint visit then last week to, assess for the physical skills for solids and positioning for that. The oral feeds are going well, but there's still a little bit of a reflux issue. So pushing towards trying some solids would be helpful, but the baby's just taking little tiny amounts and then refusing. His core skills are quite poor, so that's the bit around your sort of tummy area, and we know that having core skills that are strong and supported is important for developing taking solid foods. So the baby's also seen for physiotherapy as well for this core strengthening exercises and advice. So we've liaised with the team about possibly retrialing a reflux, just to see if we can get, dampen down the reflux issues to help the little one move on. Does have a keyhole heart surgery date for the end of May. So we want to try and keep things, as stable as we can for that to happen. And then this is up to last week. There's a further joint appointment with the CCN and health visitor planned, which has taken place. So that's where we are with him at the moment. I did it as a case study because I thought it was a good one to show perhaps a different type of team for, integrated therapies. So we've got input from myself as the speech and language therapist as part of BHFT, and from the health visitor, and from the dietitian. And then we have the team at the Royal Berks, which is the paediatrician, ENT, physiotherapist. We've got a community children's nurse from our trust, and then occupational therapy service from social services. And that is the end of my presentation. And if you've got any questions about it.
Rachel, thank you very much. I have to say, most impressive integration of all the different factors. It's wonderful to hear. Mark, I think you've got your hand up, and then Aileen.
Yeah, Rachel, thanks ever so much for a fascinating presentation. And as that last diagram showed, it really does pull together so many different disciplines in terms of that MDT approach. The one that was missing, though, at the very end was the reference that you made to the peer support from the other mother of a child who was supporting. And that really fascinated me because I've seen that work so effectively in some of our mental health work in different parts of the county where peer support is used so effectively. And I wondered, is this something that you do quite regularly, or is it a one-off because of this rare syndrome that the child's suffering from?
I mean, it's something that I sometimes do because the children come up on my caseload. For example, I did it for a couple of mums, both with a child with Down syndrome. The other way it happens, I think, introducing, parents together is, well, particularly for Wokingham run something they call play buds, which is any child referred for early intervention into the local education service. The early intervention teachers run a play bud session. It's basically for under 18 months with special needs, where they get the mums together, and they run a session, and then they have they've been doing it online over lockdown, but then they link in people like myself and so on to offer some training or support, or just respond to questions, and that works very well. So I've just always done it. Sometimes parents have come to appointments, or maybe if we've ever had a group session, and met each other, and sometimes made friendships that way, or made support. But I agree with you. I think it is very valuable. Yeah.
Thank you.
Thank you, Mark. Aileen.
Yeah, hi, I was going to mention about that peer support. That sounded really, really fascinating as well. Really interesting presentation. I haven't come across anything like that before with difficulties in young children. Is it very common for you as a speech and language therapist to be dealing with, you know, infants and babies that have problems eating and drinking? I guess I hadn't come across it, so I just didn't.
Yes.
It's very common, isn't it? Oh, right, okay.
Well, yeah, it is quite common. Not the level perhaps of difficulty that in this case study, because it's an unusual syndrome and there's factors, but it would come up for lots of other anything with the child with physical difficulties, anything where there's been issues of traumatic birth. And also we do see children with developmental eating and drinking difficulties. So some of that's linked to perhaps delayed development of skills or issues around the weaning side, parents being worried that there's a physical reason that their child's not moving onward. And we work with the health visitors. So the health visitors would be the first port of call for advice. But then if they feel there's a more involved difficulty or they need further advice, then they're referred to our service, and that's East and West, that community service. So yeah.
Okay, thanks so much. Yeah, really, really interesting.
Thank you. David, then Chris and Julian.
Thank you for your presentation. Depending what N stands for, this is not rare, it's incredibly, incredibly rare, isn't it? Unless it's nephrotic syndrome or Noonan syndrome or something. So we're talking about something really uncommon. What's more of your day-to-day work that you do, and what things would you like to see more of that you can help with, but perhaps aren't getting through to you?
Well, the main part of my work is taken up with children perhaps with developmental eating and drinking difficulties. Because we have a contract to work on the acute paediatric ward, including special care baby unit, we are involved with those children that I've just described. And then the other part of my role is working with children with complex communication needs. So children who've been born with cerebral palsy or Down syndrome or other complex needs, and sometimes undiagnosed children. So that's the sort of bulk of my day job. I think we do get to these referrals, but I think that it's the same story as in lots of other areas of the trust, where I think sometimes demand is exceeding capacity. So I think sometimes I'd like to get to them earlier, be able to respond earlier to the difficulties, to address that need, because it's very worrying for parents with these difficulties. For the feeding side, it happens 3-4 times a day, 6 or 7 when they're babies. And so, it's difficult for parents to come away from the issue, and they do get very worried. And also, for children with complex needs, they may have experience of working with children, who've developmental difficulties, or perhaps another child of theirs has had a communication problem, but it's quite different when faced with a child who's likely to have very long-term needs and a need for alternative communication. So we teach Makaton Sign Language, and we also use communication aids, so picture symbols and voice output communication aids. One child I've got being assessed for an eye gaze device at 3 at the moment. So, it's very varied. But I think that would be, it's just, helping these parents and supporting them, early, and, sort of, trying to help them to have the skills to help their children.
Yeah. Thank you.
Thank you, David. Chris.
Hi, Rachel. Again, very interesting presentation. And she was accepting that the particular case you talked about, there was a clear and quite serious issue to be dealt with. I mean, clearly issues of feeding and are probably the greatest source of new anxiety for new parents. And so it's great to see that sort of the multi-agency thing working so well. You mentioned at the start that the services commissioned in the West are different to those services commissioned in the East. Is there a piece of work to be done to convince the people in the East that they need something that we've got in? I guess what I'm saying is, do you believe that the commissioned service that we've got in the West is particularly effective and one that others could learn from?
In the West, one thing that's helpful for parents is the fact that the same therapists who are on the ward can then see them in the community, and that exactly. There's a sense of continuity there. But in the East, there are speech and language therapists employed by the acute trusts within Frimley Park and can't remember the other one. Sorry, who see children at that young age, and they have a very good handover service. So we are in contact with them, and also we have various networks for speech and language therapists working in the area. So we liaise and link in that way.
Thank you.
Okay. I hope that answers it. I know Minnow is nodding, and you may have something else to say on it, but
okay, thank you, Julian.
Yeah, just thanks, Rachel. A workforce question, really. So I was quite intrigued about the range of work you get involved in, particularly that bit that you said in hospital and out of hospital. So is it an attractive bit in terms of speech and language? Is your work attractive, or is it more attractive? Is it more skilled? Just tell us a little bit about, is there a pipeline of people wanting to work in this in the future, or are speech and language therapists wanting to work elsewhere for other reasons? Do you know what I mean? Is it?
Yeah. No, I think it is an attractive post. There's a piece of work nationally that they're trying to get going about funding speech and language therapy and other therapies for the neonate population. And so we've been involved with that. That's going through the Royal College of Speech and Language Therapists because there's not often designated time allocated to that population. A lot of the time it comes from other parts of, the service. I think it is an attractive area. We've actually got a post free in Dingley at the moment, so we're hoping that we'll be able to recruit into it. And also the Royal College of Speech and Language Therapists are just starting to put in a programme where eating, drinking skills competencies form part of the pre-registration training for speech and language therapists. So because it should put us on a par with other countries where, Australia, Canada and so on, eating and drinking skills is part of their, programme. So hopefully that will ensure that people coming through have the skills. And because I'm a lead clinician for dysphagia, that's my sort of specialism, then we've run in-service training for speech and language therapists working in the special schools and anyone really who's interested to foundation level competency, which is a set of competencies from the Royal College. So we're trying to instill therapists in the service generally. But the neonatal stuff is more specialist, and there are recommended specialist postgrad courses that are available, which I'm going on one finally in September, hopefully.
Thanks, Rachel.
Thanks.
Rachel, thank you very much. It's an absolutely fascinating presentation and really interesting, and it must be very, very rewarding for you and your colleagues dealing with these cases, and also so reassuring for the parents. I mean, it must be wonderful.
Yes, I do enjoy it. I've been in the NHS for something crazy like 33 years, so I'm still here. So yeah, you've
got many more years ahead of you, I'm sure.
Oh, I'm sure.
The only comment, which is sounds rather flippant and silly, but as a layperson,
yes,
is the title speech and language therapist, where the more I understand about it, the more you realise it's a much broader range of competencies than speech and language. And I just wonder, just off the cuff, whether somehow your professional body could think of a title which better represents the full span of all the activities you get involved with. But that's it's a silly thing, and
there's been many debates about it in the past. So yes, I agree with you. But yes, communication, I think, and feeding spans it all.
Yeah. Anyway, great stuff, and thank you so much for your presentation this morning. We'll let you get back to work.
Lovely. Thank you very much. Okay.
Thank you very much, Rachel.
Bye.
Okay, well, that was a great presentation, really interesting, I thought. But we better move on. Item 6.1 is the patient experience report, Q4. Debbie.
Yeah, so, oh, excuse me. It's for noting, really. I'll be happy to take any questions. There's really not a lot of significant difference between this and last reports. We have got a bit of an update in there about the I Want Great Care tool being developed at the moment that will be piloted in Q3. And also just to note, the Ombudsman doesn't particularly affect us too much. You don't have lots of referrals there, but they have got a really significant backlog, and they are only going to be focusing on those complaints that have had serious harm and impact over the next, I think they've got something like 3,000 complaints to plough through, hence asking us for more information on our couple that we received to decide whether they're going to take them forward at the moment. A couple of complaints related to COVID, and other than that, nothing specific to point out.
David Buckle.
Thank you. Incredibly detailed report. So everything I think I could ask is probably there. But there was a table about complaints compared with other and similar organisations. Frankly, I don't think we've ever been able to make a reasonable comment about our level of complaints compared with similar NHS organisations, or am I wrong?
No, you're absolutely right. It's a national reporting thing that we put in here, but no, we haven't. When we've got the new patient experience tool, it may well be possible, because Oxford Health also use I Want Great Care, and it may well be possible for us to do a bit of sharing across and benchmarking across, which I think will be really helpful. I Want Great Care also working with a number of other community and mental health providers across the country. So I think that gives us scope for being able to do some comparison that we haven't easily been able to do before.
I mean, what might be helpful but probably impossible is to know not only the numbers but the percentage of upheld. But I think, to be honest, there are times upheld is a bit
that would be a manual.
Not an exact science.
No.
Okay. Thanks. Good report, thank you.
Chris.
Debbie, and I really don't want us to come across as a pedantic point at all. I just think when we, on page, for instance, page 38, when we are contrasting the age of our patient, or rather the percentage of complaints by age group compared to the population, I mean, clearly, I suspect it's probably because you have to present the data like this, but it's pointless, because actually the number that we should be comparing against is the age of the population that we are serving. So, you know, for instance, when you look at, you know, to make, if you're going to use this to try and draw out conclusions like, you know, quality related conclusions like, you know, are particular age groups receiving as good service as others, to compare about 11% of our or rather of our complaints being aged 85 and over, with under 2% of the population, you know, it's a bit of a nonsense, because I suspect that probably 11 or 12 or more % of the people that we actually serve probably fall into that category. So if we were going to be using it for a sort of an analytical review sort of effect, then it would be better to be, and I realise that you know, that absolutely doesn't need to be a, should we say, a continually updated thing. Just to know that broadly our patients fall into, by age group, fall into following bands would help as you're comparing here, to be able to see, we've got something brewing in the 55 to 59 age group, because we've got far more complaints in that group relative to the number of people we serve. Let's dig into it. So it's just a suggestion for how the data could be improved, rather than any comment on the data itself.
Thanks, Chris. I'm not sure if that's possible with all the different systems we use, but I will look into it and see if it is.
As I say, you probably only need to do it once at the start of each year or each 5 years. It's just to give you a benchmark that says, you know, broadly our patients fall into these groups rather than those groups. And because when I looked at it, I thought, gosh, my one takeaway was 85s, 11% of our population or of our complaints come from that group, but 5 times their representation in the population. And then you think, actually, that's just not the case. That's just not the case. If you looked at our groups, it would be much more skewed towards that age group. So don't feel the need to update it lifetime, just an indication.
Okay, thank you.
No problem.
Thanks, Chris. Debbie, I've just got one thing, just a sort of a interesting thing about CAMS waiting time. The complaints seem to have gone down with CAMS, and on table 1 it's gone down, and there's a comment on page 40 about no contacts raised in the quarter about waiting times of CAMS, and traditionally we've had, you know, quite a challenge with CAMS. Is this you know, significant shift, or is it just something to do with COVID restrictions, etc., or don't you know?
Honest answer is I don't know.
Okay.
We haven't got significantly reduced wait lists within CAMS, so you know, nothing's happened over the quarter that's meant we've got no people waiting. So I don't think it's to do with that. It could be to do with COVID, less people, although we've had more MP inquiries this quarter, which isn't a surprise leading up to elections. We do see that sometimes. So I probably wouldn't put too much weight on it on one quarter, if I'm really honest.
Okay, all right, that's fine. Well, thanks for that, Debbie. Any other comments or questions? No. Okay, that's fine. Thanks so much, Debbie. Could we then move on to safe staffing reports?
Oh, sorry, Martin.
Mahmouda, yes, please.
Sorry. Just to comment on the virtual consultation survey at the end, and just interesting that I mean, first of all, the level of responses, which is very good, 1,500, which is great. And then the other thing about more people still prefer face-to-face if they had the choice than virtual. Then not that much in it, 34% and 37%. So that's interesting, isn't it?
Yes, a sort of interestingly, it was showing that the young people liked face-to-face quite a lot. But I think maybe some of that's because it feels like a proper private space for them. So if you're at home in a room, you've got your parents there. If you're in a consultation room behind a closed door, no one's going to walk in. There's definitely some elements of that for some young people. That's come out in some of the work we've done around that. And I suppose it's probably like the rest of the population. It's probably, you know, some people love it. Some people think is okay in some circumstances, and some people hate it full stop. You know, it's a mixed bag of pictures. So I guess I'm not surprised we're seeing a sort of 50-50 split like that, with a number of people wanting a blended model, which is what we would want to go to, really. You know, where it works, we use it. Where it's sensible, we use it. And where it's sensible to see people face to face from a clinical and safety perspective, we see them face to face.
Okay, thanks so much, Debbie. And just to thank you, I think it's always good to have the formal complaints close report at the end, because it just gives particularly lay members, you know, a chance to sort of understand the sorts of issues. So it's useful. Thank you very much. Could we move on to 6 monthly safe staffing, please, Debbie?
Yeah, thank you. So again, this is really for noting mainly. I mean, I think it's fair to say that COVID's had quite an impact on us over the last 6 months. This report covers October till March, so when we were pretty much in the second surge or third surge, depending on how, but in a COVID surge. So therefore, we did have quite a lot of staff absent, not only through sickness but because of shielding, and actually we had an increased number of staff from February onwards shielding than we did in the first wave, because of the government's changing in criteria, and we also had people obviously self-isolating. We had wards where we were needing to cohort COVID positive patients. So we had some wards like Daisy Ward, where it looks like we had lower occupancy because we had beds waiting for if we needed to cohort patients. So I probably wouldn't put too much stall on this being a normal 6 months. It's a 6 months report, but is certainly not a usual 6 month report in terms of all the goings on that were happening. The other thing is we saw quite an increase in the number of shifts without 2 registered staff in this 6 month period. Again, given the national challenge, the COVID impacts, then that was seen across the country. I'm not surprised. We would say that services were safe during that time. We didn't have any significant incidents as a result, but it certainly wasn't ideal. What I would say is between March and April, we've seen an almost halving again back to a more usual level of numbers of shifts without 2 registered staff. So we have seen that drop back down quite significantly between the March data and the April data. So I would expect the next 6 months to be a more usual picture.
Thank you.
So yeah, and then I'm happy to take any questions.
I think we've got some questions. David Buckle and then Chris Fisher.
Thank you, Debbie. A very clear report. I guess you'd expect me to comment on safe staffing because, as I always say, it's evidence-based. It's there for a reason. It's there to protect patients and us, I suppose. And I completely recognise that safe staffing levels have been seriously affected throughout the NHS and frankly in other areas worse than they've affected us. So pretty scary with NHS boards taking a level of risk that I've never seen before. We need to recognise that before COVID impacted, our safe staffing levels actually were doing well and improving. So my 2 questions are, how do these, I'm specifically talking about shifts on our wards where we only have 1 registered nurse, and accepting, of course, that the management does a lot to mitigate these circumstances. So my questions are, how do these figures on 1 or 2 wards in particular compare, with previous ones? You've already mentioned this is perhaps a unique time. And secondly, accepting that management does everything it can to mitigate, what on earth do we do if mitigation is not enough? What do you do? Do we just accept the risk? Do you alert us? What would happen if we reach that critical phase?
So the we always move staff around, and Prospect Park's probably slightly easier to do that in terms of making sure we can have safety across our wards. And look, we do now have the associate practitioners who are registered with the NMC and can do a level of intervention, including giving medications, but don't count within the 2 registered nurses. But certainly the West Berks Community Hospital and Prospect Park have got 1 person who is able to step in and absolutely support in those times. So as well as the more senior staff that come in or work across wards or move around, we do also have some very, very competent associate nurses across our wards now that step in and help, although they don't count in these numbers. We also move staff across our community wards now. They've got much more used to doing that. So the chance of having an unsafe situation where we haven't been able to move people around in order to look at need acuity numbers on the wards and make the best decision we can, I would hope would be pretty much never. It didn't happen during COVID, so I would be really worried, and then they'd probably be calling people like me, David, if I'm really honest. So I keep up my skills should I need to work on a ward. So I would hope we were never in a position where we couldn't bring people in from the community or find people from elsewhere move people around our wards to make sure that we had a safe situation. We have a lot of community. So in the past, we have used community nurses to come into the wards if need be, for example. So there is that option available as well. Sorry, you're on mute.
Can I just add to that?
Yeah, can David Townsend just come in, because it's
so the other thing we've got, David, just to reassure you that if we're in that position, what would we do? And as a board, how would we know that we're in an unsafe position and what are options? So we have business continuity plans, and obviously our wards are at the top end of that. So if we're in a position with the ward, you do everything you would expect in terms of dealing with that. It depends on your analysis of the situation about whether you think it's a problem for a couple of days or whether you think it's going to be a problem that will last you a few weeks. You've got options like closing beds, you've got options like moving people into out of area. So we have as part of our planning in worst case scenario around reducing the number of wards that we have and then distributing the staff that are there. As Debbie said, you would then start, if you got really bad over longer term, you'd start closing less critical services and you would be moving staff into the critical services. That's what the business continuity planning does. So all of those plans are in place. So you would assess the immediate issue and deal with that with a number of options that you would have, but then you would also have a number of longer term options. And I think it would become a board issue if there were an ongoing situation where we had to, employ some of those tactics rather than something for a day or two where we're moving people around.
David, you're on mute. David Buckle, you're on mute.
Thank you. So my translation of that is you do everything you can to keep going, but you have levels upon levels of surge and backup, and the longer it goes on, the more you bring up your business continuity strategy. Okay, that to me that's a great answer.
Thank you, Chris.
Thanks, and Debbie, and if the right answer to this question is actually that David just asked it and it's got answered, or I covered it in the because it's all COVID related, then please put me in my place. But I was interested. We've seen this comparison on acute skill mix. I think on page 67 or something like that, comparing us to others. I'd just be interested to know what your takeaway is on that. And secondly, bearing in mind that the recommended establishment levels take into account things like acuity and all of those things, they've been developed by the people that know what these things ought to mean. The difference at individual ward level and in total between the recommended establishments and our actual establishments are really quite large. And in some cases they're up and in some cases they're down. So the recommended establishment at March 21 on Bluebell, for instance, was 49, and we've actually got 35 current establishment, and including all shifts as requested, 42. So, quite a big gap. And then you see quality issues around Bluebell, perhaps in other places in the overall papers. And then on page 68, you look at Campion and say, we appear to have a situation where and again, put me in my place if I'm asking too basic a question that I ought to know better about, but we've got a situation where we've got 4 patients at March with a recommended establishment of 12, but we've actually got 37 in place. It just, if there'd been a small difference, I could have said, well, that's just the way it is. But when we're struggling in so many areas, to see differences like that just makes me wonder if our workforce planning is as sharp as it might be.
So firstly, the benchmarking, there is a bit of variation. If we were at the national, which was 45% instead of 40, it would equate to about 1 more registered nurse a week on one shift. It really wouldn't make us it wouldn't make a difference on every shift. So I think we've got the balance around about right in terms of the registered and unregistered, bearing in mind the workforce supply. If it would help if we obviously could recruit into all of those, because obviously some of those are vacancy at the moment. We do want to look at the therapy mix, because I think there is something around having a slightly richer therapy mix potentially that does assist with your length of stay. and other things. So that is something I put as a recommendation in the last piece for us to have a look at. So we're spot on in terms of the national average, but I've made some links with Solent, who we know have got slightly higher percentage of therapy and have a much lower length of stay. So their head of psychology, their head of OT is linking in it with our counterparts around that to see what they do differently, what does that mean in reality, type of thing. So I think that will be helpful.
Great answer, thank you.
In terms of the whole time equivalents and staffing, so no, we don't think the tools are 100% perfect at the moment. They don't take into account physical and mental health requirements so brilliantly. So there's still more work going on around the mental health tool, and actually we're going to be involved in some of that so that it captures it better. With Campion, it has to have slightly more staff because it's split across 2 levels at the moment, so up and down, and as opposed to being on 1 floor, which makes it slightly more complicated. And I don't sit here thinking we got far too many staff on Campion ward. We did have, for the period they were doing it, lower patient numbers than normal, but very complex people, and the tools don't always take into account the need for 2-to-1, for example, in quite the same way as you would hope they would. So whilst the tools are a benchmark, they are a benchmark, and actually the care hours per patient day that we look at, which is used nationally, are also seen now equally as importantly, although still have their flaws because they only count allied health professionals if they're rostered onto the ward, as opposed to ours, which are in a pool at prospects. So they all come with, none of them is perfect, shall I say, Chris. We need to look at them all in the round and use a lot of clinical judgment about whether we think they're right or not. So it's a method.
Yes, and I totally take that on board, because anything that's a snapshot at a point in time can show a slightly peculiar picture that you should say wouldn't be typical. And when you talk about 2-to-1 and you have a 3-shift system and a 7-day week, then you can quite easily get to the need to have, 6 or 7 people per member of staff. It's just when I saw it going over 10 or something like that, I thought, that does seem quite a heavy deployment of what is a scarce resource in one area, when, as David was pointing out earlier, there are other areas where you kind of wonder whether we could do with just a little more. And you looked at Bluebell, and I know the skills are not interchangeable, but you look at Bluebell and you see some of the other quality issues, and you just wonder, is there a tweaking that's possible here to, help overall? But I take your expertise.
Thank you very much, Chris. Thanks, Debbie. I've just got a few things, if I may, Debbie. I think Chris has sort of asked this already, but just to make an observation, really, that whether we can be clear about the sort of skill mix and using band 4s and people like that, and other types of skill therapists, occupational people who can help with managing the mental health patients in particular, to relieve some of that load off the registered nurses. Have we got a sort of a clear model of that? And I think what you said, you're talking to Solent about some of that, and I think that to me as a layperson sounds really a really good idea. The other thing in terms of just the paper and the various models that you have, to estimate what are safe staffing levels, it's a great paper and it's very detailed and it's very clear actually in each of the sections. I think for the lay reader it might be helpful if somehow those bits that are the various ways of modelling safe staffing levels could be drawn together to arrive at a conclusion before you go on to the actual things. I know it's difficult because you're familiar with it, but as a lay reader you tend to read this model, that model, that model, and you're not quite sure it comes to a conclusion. So a little summary there might be helpful to say, and this is what we're going to use as our metric against which we're going to compare things. I think it might but that's just sort of a minor tinkering. And my final point really is that I think what this reflects is the hard work of all the staff in the Trust during this recent pandemic. And I think we should record our thanks under very difficult circumstances for what all the staff have done. So thank you to you and your colleagues for that, and to David and his colleagues too. Okay, is there anything else, or can we move on? Right, thank you very much. Thanks, Debbie. Quality accounts. Minu, I think this is not going to take us very long, I suspect, as we've been through this on several occasions, but I'll leave it to you and my colleagues.
Thank you, Martin. I mean, I'll just give the usual preamble I give, I think, every year to put this into context. It's a long read. So the quality accounts are not a compendium of every quality issue in the trust or every quality concern in the trust. It is a sort of a cutout of some mandated parameters that we are required to put in there from NHSE and I. For colleagues who like absolute numbers and targets, we have sort of page 91 where we draw everything into a table about whether we meet targets or not. For colleagues who like sort of a narrative about quality improvements, we have service-related reporting of quality improvements and highlights from page 123 onwards. And in between those two, we have a number of mandated metrics that we demonstrate either in a numerical form or graphical display. So is it a governance document? No, it's not a governance document. Governance is ongoing. The board and everyone else has seen everything that's in here throughout the year. By the time this document is published in June of the year after, it's too late to do any form of governance. So it's not even that. This year is different. It was to some extent the same last year, that we don't require any auditing by the trust auditors. This is sort of a national directive now. So normally the trust auditors would have been through two aspects of it. One is look at the whole quality account and just sort of link it to the various board papers, executive papers, and say, well, yes, what you said there is true to the quality accounts. Nationally, they don't feel that's going to be required, at least for this year and possibly for the future. And the other is the governor's metric was audited in detail, just again to determine if the data collection method, etc., was sound, and that's not required too. So they've removed all of that. So the ask of the board, I guess colleagues will ask, so what are you asking the board to do? And the board is looking at, you know, the information which is there in this report. As a sense check, is it something that the board is aware of, has seen, is not completely out of line from what their expectations are, and that's what they are sort of signing off as directors and chairman and the CEO. So that's my sort of preamble to rather lengthy piece of information there. I find it useful from time to time to go back to determine, you know, some improvements in services, some data about equality. But it's by no means everything of every service in the trust. That's not the intention. It never is for a quality account. So happy to take any questions, comments, thoughts from colleagues.
Thank you, Minu. Chris.
Minu, it may be a long document, but for those of us who don't attend QUAC, I must say it's one of the ones I look forward to most, because it really does bring together so many things across the organisation, and it just sort of, if you like, it drags together the reason for our existence, and it's I find it interesting and informative and all those things. And if you say to me that the quality account itself is not the right place for this particular thing to be aired, then I take it on board. In the accounting, in the finance world, when we produce our annual accounts, yes, it's a snapshot, it's a look back of things that have happened over a course of a year, but there is something called a going concern, where we look at, okay, and are there things at the point that we're signing this really materially affect our view on the ability of the organisation to continue as a going concern? And that's a judgment that we and auditors have to take every year. And I just wonder if it's the place for the quality account or other documents, on the basis that it's the squeaky wheel that gets eventually oiled rather than the others. The feeling that we've got going into this year is that there's, I suspect, a material chance that some quality items of quality could, as a result of the output of the, as a result of COVID, could actually go backwards. And by that I mean, you know, the sheer exhaustion of staff coupled with the suppressed demand over a period of time, coupled with the wait lists, coupled with the workforce shortages more generally. And I wonder, is there a better place to be able to make a signal to the outside world about the difficulties that NHS trusts are? I mean, a lot of people are going to download this thing and look at it and read it. And if it's not the right place for it, where should we be making those comments to the outside world that, you know, that life is tough and possibly getting tougher from a quality angle?
Well, that's a philosophical question, Chris. I mean, I guess a lot of the information is in the public board minutes. So, you know, these meetings and the minutes and papers that go with them are all available publicly. Minu, do you have a view?
Sorry, I have to say my connection dropped off when Chris was just about trying to explain. So now I'm on my phone connected through. Chris, sorry, do you mind just repeating your question?
Yeah, I'll give you the engine highlights. The engine highlight was that in our annual accounts, we not only report on the year just gone, we report on the year to come. Insofar as, are there things that we know about that materially affect our ability to maintain the services that we currently provide? And given that we sort of, you know, we're proud of the quality improvements that we've made over time, and I think that we probably all agree that the combination of an exhausted staff, the overall shortage of staff in the system that are available to us, longer wait lists and probable increases in demand, has there ever been a time when there's the chance that quality could actually go backwards? And whilst I don't think that is a, if you like, going concern issue, I wondered if there's a better place. And I know that we produce lots of things in lots of accounts, in lots of board papers, and if you look for them, you'll find them. It's not really a disclosure thing for me. It's a, you know, making a point to the outside world that the situation we're in is complex, difficult, and stressed by the situation that we now find ourselves in. And would a quality account be a place to flag that, or are there better places? I'm not talking about reporting it, because clearly we do that, but making this something of an issue of it is, I guess, what I'm saying.
Yeah, I think that's a very intellectual question, Chris. I don't know the answer to that. It depends on what the board wants of the quality accounts. So if you ask me very simply, during the pandemic, has the quality of services reduced? And I'm not talking of this trust, I'm talking of the NHS in general. The answer is yes. Waits have gone up, diagnosis have been missed, and there's all sorts of issues associated with that. Would you like us to put that in next year's quality accounts if we find something which is a significant departure from the quality that we strive to maintain? Yes, of course, if the board requires, we would do that, but we should be doing that on an ongoing basis. So I wouldn't wait for June 2022 to find out if we did a good job or if we are in real trouble post-pandemic. I would ask at every board meeting, you know, that's the quality concerns. Debbie provides the mortality review that I provide, and a report will be coming to Quack about how we're doing with all of that. So, Chris, there's no simple answer to a really good question. What the board wants, we will provide, and the board is seeing everything about quality month after month and through various subcommittees. And whatever you think is essential, we will add it to the quality accounts. We're perfectly happy to do that.
Okay.
Well, I'll shut up and leave it to others to comment.
Thanks, Chris, for your question. Naomi.
Yeah, thank you, Minu. I really like this report. I think it's an excellent way to kind of capture and summarise performance over the 12-month period. And the other part of it that I really like is the kind of external points of view that are provided at the end, and I take considerable assurance from those, because it, you know, we whilst we see the quality of our service every day, externally see this from a slightly different perspective when they get the report. So I think I just wanted to acknowledge that, you know, the Council of Governors, the commissioners and the local authority and the perspectives they take from the report, and they all have various different ways of looking at it and, you know, asking you to respond. And I think my reflection across those three, particularly in respect to the last 12 months period, is that they all thematically kind of congratulate you for maintaining a high level of service, and at the same time recognise the volatility that you've had to do that under over the last 12 months, which is, I think, something that we as board members would all take away. So I think I just wanted to acknowledge that, because that's where I derive my deepest assurance from this report, apart from the detail that's inherent to it.
Thank you, Naomi. I very much agree with that. That's so when we were told we don't need to do an audit, and I asked, of course, Jason Hibbett, who is the architect of this entire report, is actually an observer of the trust board meeting today, incidentally, or it happens year after year. That Jason likes to be here on the board meeting when we are presenting quality accounts. But Naomi, you're absolutely correct. That is a form of assurance, the best that we can get in the circumstances that our governors, CCG, oversight committees, external stakeholders have also scrutinized the account to some great detail, have provided their feedback. And most of the feedback is very positive. They've asked a few questions and we've responded there. So thanks for that observation.
Thank you, Naomi. Minu, I think it's I too find it a very interesting paper to go back into and look through, because it does summarise everything, and I think it forms an important part of the transparency of the trust. That it is there. It doesn't contain everything, it can't, but it gives a very good summary and enables not just those with our colleagues in other organisations, but the public a chance to, you know, go through to the bits that interest them. So I think it's a very good paper. I think Chris's points are interesting ones about going concern type things. Perhaps we can have a discussion in a slightly more leisurely way about how we might do that. But this has to conform to certain regulations about what it contains. I think it's very well done. So Jason, thank you. And on page 151 of the pack, there was a statement of directors' responsibilities in respect of this report, where Julian and I need to sign to confirm that we're content that it complies with the regulations. So I just refer you to page 151 of the meeting pack and ask if anyone has a reason why Julian and I can't sign that statement. Everyone content? Thank you very much. By the way, just for Julie, there's a slight sort of minor technical thing that the pages in the report, i.e. the pages of the original document, aren't visible on the pack numbering. So where the text refers to page 66 of the document, you can't actually find page 66 of the document. You have to look at the page number of the pack. But it's a trivial matter, but it just sometimes makes it more difficult to read. Okay, well, thanks so much for that. We'll move on, if we may, to the exec report. I guess, Julian, you'd just like questions?
Yes, please, Martin. I mean, I think it's quite a short report. I'm really pleased with the work David and colleagues have done in terms of what has been a fantastic transition, you know, closing the inpatient unit and moving to a sort of potentially more contemporary offer. I think there's a lot of things in that, Martin, to unpack, you know, the communication with stakeholders that David and his team have done to sort of get confidence. And then, you know, we've turned this around so that we've got a model that we're particularly proud of, that we think actually something we should keep an eye on in the future to see the impact that it's had. Because if we are able to keep many young children at home, that's going to be a great success, really. So I don't know, David, if you want to say any more around that, and then we'll just take some questions. But I think it's been a great piece of work, which behind the scenes have been a heck of a lot going on, but it's got us into a good place, I feel.
Perhaps, David, you could just offer a few comments before we get questions.
Yeah, well, thank you for the thanks, Julian, but really it was down to a lot of people and a lot of hard work. So I think we've had a lot of clinicians involved in the developing of the new model, and that's really exciting. We've got people really interested to come and work in this new service. I think the existing team at Willow House, you know, if you think about where we were and the risk we had of continuing to run a safe service, no certainty around commissioning, and no knowledge about whether the new model will be supported, I think, you know, Alex has been involved with all the contract and the finance, clinicians have been involved, the project team have been involved. There's been a lot of work across a lot of domains, and it's all down to that team, which is why at the end I just wanted to reflect how far we've come. It's a great news story, and that's down to, you know, all of the people on the project, not down to me, getting us to this position. So I think from where we were, yeah, this is a really great outcome. Thank
you very much, David. We've got a few questions. Chris?
Thanks. Yeah, like as you said, David, it was so good to be able to read something that was so clear relative to the sort of the murk that we've been in on how this is going to end up for sort of the thick end of a year. I took great assurance from it. I suppose, having worked on both the commissioning and the provider side inside an organisation, the thing that intrigued me was the comment at the bottom of page 182, the bit that says that a provider collaborative led by Oxford and us with other local providers took on the responsibility of commissioning. And I completely get the point that's being made. Now, commissioning is a misused word. All it really means is designing the service that you want and B, paying for it. I wonder how how does that really work? I mean, I guess it will be different in ICS, in the ICS world, but let's say, and use it as a live example, let's say demand doubles over the course of the next 12 months. How do we, as the commissioner of that service, with nothing in our pocket to respond to the needs of the provider, how do we deal with that situation?
Yeah, so as one of the members of that provider collaborative, we have a joint agreement between all of the parties, and then there's an agreement between all of the parties and NHS England. So NHS England, who were the previous commissioners of this service, effectively subcontract, for want of a better word, the collaborative. They give them all of the money, and they say, you decide how to run it, you take the benefit of any savings related to that, or determine what model you want, but you also take the risk if you overspend as well. So it would be the same with NHS England. If we were to overspend, there is an agreement between us around how we would handle that as a provider collaborative. And there's also, as part of that agreement, what we do around a share of any savings that might come out and how they might be reinvested going forward. So I think there's lots of safety mechanisms in place in those agreements for providers to work with one another and between us and NHS England, because it's a new development that's being rolled out across the country. And obviously everyone's hoping that we won't be in a position of talking about an overspend. We'll be in a position of developing services in a better way because we understand our local populations and we're running the services. So we feel we're in a better position to understand how we can develop that going forward, and that will lead to better care and more productive delivery.
I mean, that's a very mature answer and very sensible. Do you think it sort of changes the nature of the reports the board should be receiving in the longer term? Because what you're currently saying is the money, the pot is the pot, and that pot is put there for this particular care group over this group of people over an entire and much broader system than just Berkshire and Berkshire Healthcare Trust. Somehow this board surely needs to understand not only its place as a provider of services, but also, if you like, the broader commercial commissioning financial risk that's occurring within an area that we've, if you like, taken a pooled view on. Somehow, and I'm not suggesting it's every week or every month, maybe it's only every year, but somehow knowing how, what's happening in here, because as you said, there is no more money. And Alex's hand's just shot up, so I'm sure he's going to put me in my place.
So we needed to agree the provider collaborative MOU to get this over the line with NHS England on the 1st of April, which we have done. We have not yet agreed within the collaborative the risk share arrangements and the commercial arrangements around those risks. So Oxford Health have agreed to hold all of the risk until such time we've completed the due diligence on the 5-year view of what is a 22 million budget that's transferred into Oxford Health. So our position at the moment is we're contracted in full for the value we need and transition costs for the new community model, and we'll progress risk share discussions, which I will bring back to the board before we sign those off, so you understand the risk profile and the commercial arrangements.
Thank you very much. Mark?
Yeah, I just want, when I read the report, I was delighted to read in terms of the staff implication that David and the team had been successful in redeploying all of those people that previously were employed at Willow House into other services. As too often in situations like this where services are closed or transferred, staff themselves just use it as an opportunity. It's almost as a catalyst to say, is this something I want to continue with or be redeployed? And to have that level of success is tremendous. The second part to it, though, and a question for you, David, is as a board, we've obviously been made aware of this, and I just wonder whether or not the workforce overall and Berkshire Healthcare will be advised of that success and the fact that whilst people will be aware that Willow House itself has closed down, I wonder if they will be aware that we have been successful in redeploying and maintaining that employment for those people, because that's a real success story. That as an executive team, you've taken care of those and ensured that continuity.
Yeah, it's a very good point, Mark. I think we've had a comprehensive communications plan. I think as part of that, within Team Brief, we've kept people informed about the changes to Willow House and about the new model, but we haven't done anything explicitly around celebrating the success of what we've done or how we've looked after staff and made it more of a good news story. So I think we should certainly think about how we could do that, because I think you're right. It is a good news story, and we could benefit from others hearing more about it.
Yeah, it was with my health and well-being hat on that I made that comment, because so often closure of services creates real uncertainty and anxiety within staff's minds. And here's an example of where, as an executive, you've really taken care of those people and taken it forward. And I think it's not just a good news story, it shows real care and compassion for employees and needs to be publicised. Thank you.
Yeah, thank you.
Thank you very much. Anything else on the? Oh, Naomi.
Yeah, just quickly, and I don't think this is a question that needs to be asked because I think we would have heard, but I just want to check that in the final kind of thrust of the closure, which, let's face it, was pretty recent, did we have any unexpected reactions in the public domain in particular, and people who are close to the service from a user perspective?
No, we didn't. No, I mean, we had a little bit of press, but that was a number of weeks ago. We've had nothing over recent weeks as the actual closure's gone on. And we've obviously been working very, very closely with the existing patients that were there as we started to wind that down around the ongoing plans for their care as they left the unit. So they've been heavily engaged in those conversations, along with commissioners that would have been placing patients into that unit. And obviously we've got the new service up and running. So for a couple of the patients that were there, they've just moved straight into that new service as their transition.
Yeah, and David, this is a lot of detail, but forgive me, but it really is about the sort of patient-centric part of this, which is the handful of patients that will be continuing with the service, albeit in a different shape and form. What do you take away from them in terms of their commentary? Is it broadly positive that the changes being made are going to advantage them, or is it neutral, or is it a bit of kind of uncertainty? Just to characterize that, if you could.
Yeah, I think it's been very positive. People are very happy and interested in the new model. We've got a lot of positive feedback. We've spoken to a lot of people about the new model. So we've done a lot of engagement work with it to get input. So we had input from existing and previous users of Willow House around if we were to have a new model, what would be important to them, how would they like it to work. So it's been very positively received. The main concern is obviously if this model doesn't meet the needs of the child and they still need a bed, then what will happen? And we've been able to reassure people that in that scenario, we still have the option of placing people within our region in an appropriate facility. But what's so great about the model is all the indications are that will be less people needing to go into a bed, because this model is more effective at avoiding that and treating people more effectively and earlier to avoid that need, and a wider range of people than we could have treated at Willow House.
Yeah, no, thank you. And actually, I have to say, great to hear hear you speak about it with the changes with such enthusiasm, because that says a lot.
Yeah, no, the team are really enthusiastic about it, which has been great, and that's been one of the reasons why the transition for staffing has been good, because people were really interested in wanting to work in this new model.
Yeah, thank you, David.
David, thank you very much, and just add my thanks to you and your colleagues for such a smooth transition. Very impressive.
Thank you.
Can we then move on to the gender pay gap report, and I think Alex is going to lead.
Yeah.
Alex, this is one of those papers that where I think the data sometimes is very difficult to take on board, you know, what the numbers mean and what the words mean. So I think it'd be helpful whether you're going to do it or someone else, just to help us understand, or at least me, understand the significance. And I focused on the actions at the end of the paper, which I think is probably where I'd just like to have a bit of discussion. But over to you.
Sure, thank you. So we're required to publish the gender pay gap report. We have the retrospective results here for 2020. There is a small improvement in the overall gender pay gap. If you look at table 1 on page 187, from 20% to 19%, and that is the difference in average hourly pay rates between our male and female workforce. Now, if you look at the key drivers of that gap, it is largely explained by our representation as majority female workforce in the organisation. And then you pick up the additional drivers of females being underrepresented in the higher quartile of pay, a large number of female part-time workers who are largely female in terms of proportion, and female members of the workforce who provide for salary sacrifice, which reduces the gross pay in that particular part of the data. So our actions really are focused around bringing more males into the workforce to bring some of this disproportionate effect that we get through the different quartiles of pay between male and female, and encouraging through talent development and succession planning views of taking female workforce up through into the upper quartile, so we get a better represented workforce in the upper pay. And a lesser issue, but still a factor within the overall results, is the Clinical Excellence Awards, and continue to look to how we bring female equality through the Clinical Excellence Award bonus schemes. So it's a driver of the proportion of our workforce being significantly female, and it's going to be difficult to make fast inroads into this, but those actions are where we think we need to be progressing. Jane, did you want to add anything? I know Jane Nicholson's joined.
Oh, Jane's on the line. Sorry, welcome, yeah. Jane.
No, I think you did a great summary there, Alex. I think that's absolutely right. These things move very slowly. It's not going to change radically unless we radically change the composition of the workforce, as Alex said. And the actions, as you said, Martin, are the important ones. It's around, you know, focusing on those actions now and taking some of those forward.
Could I just ask, in terms, for example, of the Clinical Excellence Awards, that sounds to me as though that isn't a long. I mean, some of the things are sort of almost societal changes that go along with the needed for these changes. But the Clinical Excellence Awards, is that something which we can do something about more quickly, or maybe I don't understand exactly the data, but
not. So what happened, and again, Minu will probably give more background on this, but with the Clinical Excellence Awards, what was often happening was that more men were applying than women, and then they were getting the awards. Actually, when they applied, women actually were proportionally getting an award as much as a man, but they weren't applying. Now, this year we did a slightly different approach because of COVID, and we actually just gave, we portioned the Clinical Excellence Awards equally, but of course, you still got some historic excellence awards in there. Minu's got his hand up, so I'm sure he's going to tell us in a bit more detail what's been happening here.
Minu.
Thank you. Thanks, Jane. I mean, I think this becomes an emotive topic, Clinical Excellence Awards, not only for the doctors, but everyone else who hears about it. So to put it into context, these are not bonus payments. They're built into the consultant salary contract negotiations, and they're simply distributed as over and above. So that's the background context. We have to follow a national recommended NHS employers and agreed by the BMA, which is the medical union, process, which we follow to the T. And in fact, we are one of the few trusts who do it well in advance of everyone else. So if you ask me, can we make big changes about women working part-time and hence, applying and not receiving as many clinical excellence awards? No, we can't. Nationally, they would have to do something significant because they recognize the gap is far more in acute trusts and, where there are surgeons and males and, other very highly paid, highly awarded people. Our gap is negligible. Saying that, there was something we could do, and we've done this a few years ago because we found out that our female consultants were less likely even to apply, and that has nothing to do with the way the award system is set up or how we manage it. They just did not apply for it. So simple answer is you don't apply, you can't be given an award. So there was a lot of work we did with having focus groups. Individually, I wrote to all the female consultants saying, please do apply. So from an application rate, which was tiny, we actually managed to get it up to nearly 50%. So we almost had parity between male and female applicants. And the other aspect which we found out as part of the research work we did internally in the trust was that there were less female consultants who even volunteered to be on the panel which awarded the or which scored the award. So I think sort of Julian has experience with the panel. I think Martin, you will have. And that panel, the one which scores the participants. And of course, you don't score your own award anyway. Female consultants simply didn't volunteer. That's a volunteer system. We don't select anyone. So we have rectified those two aspects, what we could, what was in our gift. We can't rectify the national process, which simply means that you apply, you get scored, you get the highest score, you get an award. Now, what Jane has said is correct. During the COVID couple of years, to avoid extra work, it's not we did anything, it was a national directive again, that we simply distribute the money equally between all consultants, pro rata, so depending on how much they work. And that is something the BMA has agreed, NHS employers have agreed, and we've done that. It still doesn't remove the inequality because if you work part-time, you get less money. But that's the reality of it. Those are national directives. We can't do anything further. So we've done, I think, I've not heard of any other trust having done what we did of having more female applicants, making all those efforts and having more on the panel, because the BMA actually took our letter, which I'd written as an exemplar to sort of provide it to other trusts and say, these guys have done all these measures to reduce, because everyone is at a loss what to do about it nationally. But actually, if you look in terms of actual money, that is a tiny amount, although it does become an emotive topic because it does create some amount of inequality. Rest of the pay is entirely national terms and conditions, nothing to do with gender.
I do believe, Manu, you again may know more about this, but I think the chair over at Oxford University Hospitals was involved in some research and some work around how we could amend clinical excellence awards. But as Manu said, there's no changes being announced at the moment.
Okay, Aileen.
So my question is what's actually stopping them applying? I mean, I know you said that you've encouraged them to. Why wouldn't they apply? And then my second question, I think James just answered, could we carry on just giving out proportionally to the amount you work, or is that not possible?
So yes, when we did our focus groups with our female consultants, the reasons varied from they were part-time, they thought they'd not done anything over and above what their contractual requirements were, and as they thought, what's the point of applying because we won't get it anyway. And our position was actually, generally if you apply, you're quite likely to get, the number of turn downs are very few because we have to allocate a certain number of points every year. So yes, and after a bit of encouragement that you apply and you're likely to get, they did apply and they were quite pleasantly surprised that they got it. But that lasted only for a couple of years, because then this rule came in that you just distribute equally for last year and most likely this year. Whether we can do it forever or whether we can give everyone the same amount irrespective of how much they work full-time or part-time It's a national directive. We can't do anything about it. That's an NHS employers BMA agreed central directive which comes to us. We simply let payroll know who gets what, depending on the formula we're given.
Aileen, it was discussed at ICS level, actually pre-COVID, whether or not we could address some of these issues by just doing what we've done during COVID. There was quite a lot of pushback from the acute trusts around doing it that way, because the acute trusts often use the Clinical Excellence Awards as a way of attracting and retaining people in the hard-to-fill vacancies.
It sounds to me as well, and I've come across this in the previous trust. It's one of these sort of arcane things, you know. I never quite understand why we continue with it, and why we don't have a more objective measure of excellence for our clinicians, you know, rather than them applying or indeed sharing it out. If we share it out equally, I don't understand how that's reflecting excellence, but there we are. There
are a number of arguments for that, Martin, but this is probably not the time to
No, I understand.
It.
I knew I was going to get some pushback. I just got a comment on page 190, which I just about the data, which I just find I'd like some explanation of, if I may. On page 190, table 6 at the bottom, payment of bonuses by gender. Clearly, we have a lot more women than we have men in the trust, and I just wasn't clear what these bonuses were, because I thought the bonuses were like the Clinical Excellence Award, or
that is the Clinical Excellence Awards.
So, yeah. but it's baselined
against. It's a misnomer as a bonus, yeah.
Okay, but it's baselined against the total staff of the trust rather than those who are eligible to get it, and therefore, does it give a misleading picture?
It does.
It does, Martin. But bearing in mind that this gender pay gap report applies to all sectors, so it's not just public sector or the NHS, and therefore we get tied up in some of the language that's used in the private sector as well.
Yeah. I think it's just important, if we, as we should, make this stuff publicly available, the data, you know, the result, that we just have explanations to make sure that those who are not aficionados of all this understand and interpret it correctly. Okay, well, in terms of the actions to take on page 188 and 189, I mean, they seem to me the right things. There's always a frustration about why we can't go faster or do more, and I guess maybe some of my colleagues might, in due course, wish to brainstorm some ideas. But thank you, Jane and Alex, for that. Any other comments on the gender pay gap report? No. Okay.
Thank you.
Thank you very much, Jane. Performance, Alex.
Thank you. Bye.
Thanks, Jane. Item 8, month 12 finance report, Alex.
Yes, thank you, Martin. Pleased to present the year-end results for 2021 that are now going through the audit process, and we landed a small surplus of £100,000. That is better than the original second half of year forecast, but we were dealing with a lot of uncertainty through COVID, and we secured some additional funding for our COVID costs from the ICS, which has significantly helped us there. When stripping out an impairment, our position for system reporting purposes is a 1.3 million surplus, so slightly better than the break-even expectation from the system. And as a result of cash items backing our annual leave provision, our additional COVID allocation, and a few other items from NHS England, we've got a significantly higher cash balance of 39 million. Within that cash profile, we broadly delivered our capital expenditure plan and continue to make progress on our major programmes. The new learning disability unit in Prospect Park, so moving the Campion unit to the new Jasmine, is one of those. So very pleased to see that performance coming through in our capital programme. I will take the report as read and take any questions, but in summary, very pleasing results for the end of the year.
Thank you very much, Alex. Chris.
Just a couple of comments really, and I think there are a couple of things that just need to be minuted. And if you'll indulge me, this is the last time I will ever get the opportunity to comment on a set of year-end accounts. If we compare the budgeted and actual manpower costs pre-COVID with actual, then we overspend by 10 million quid. And if we add up the new provisions that we've been required to make that we didn't know about at the time of the budget being set, so that comes to 10 million quid. Now, I'm not saying for a second that that means there are no ups and downs and variances, because of course there are. But it is an extraordinary achievement for an NHS trust to land its most volatile line, cost line, exactly on budget. So I think that just has to be noted. And following on from that, I would just urge people never to take financial control of this excellence for granted. I will guarantee that very few boards in their equivalent meetings this month will be will be looking at a situation like this. It's a testament to Alex and his team, the execs and senior managers for taking internal controls around budgeting as seriously as they do, and the scrutiny that people like Naomi and Mark give at FIP. This is a really extraordinary example of good governance, and I think we should make comment around that.
Chris, thank you very much. I'm sure Alex will receive that and his colleagues well. Thank you.
Thank you. Appreciate it.
Any other comments? I've just got one thing, which is I keep raising and you keep telling me I got it wrong, but I'm going to do it again. On page 196, the staffing detailed charts, the management and admin staffing continues to keep going up. And I'm sure you've told me that this is all logical and, what we want to do, but it could be seen as, we've got more back office stuff, and because the clinical hours staff hasn't changed much. Can you just help put me right, Alex?
So it's more about support to clinical services rather than back office staffing. There is some back office staffing coming through there in terms of changing capital programs for IT that have come off capital and back into revenue now. So what we can do, Martin, is provide a bit of analysis regularly through FIP just to give that assurance that we've not got a growth that is unexpected or not needed within those lines.
Yeah, I think maybe, and the detail not now, but perhaps if Naomi would have a look at that at FIP or tell me I've got it wrong in due course. It's just that question I think that we need to ask ourselves, is there growth here that we need to just keep cap on? Because if you look, say, at the medical staffing, the nursing staffing, you don't see the same sort of trends. But thanks for that answer.
Martin,
any other? Sorry,
please. Just to say,
Julian.
Martin, you're probably also what's under that caption is much bigger. So medics are just medics. I suspect you've got a huge array of staff captured under that umbrella. And I guess if we unpick that, that will be the reason why. And it's probably not as straightforward as what's in your head in terms of what goes under that, because it's a default catch-all, actually, for quite a lot of other things. So again, as well as an explanation, just kind of being really clear about what's under that heading would probably be helpful as well.
Yeah. It's always difficult when we don't know the fine detail of what's underneath it. But I think I'd be reassured if FIP could just cast its eye over it just to answer the question.
Yeah, it's a really good challenge, Martin. You might recall I want to say 8 months ago, FIP did something of a deep dive into this very question, and a detailed response was forthcoming. And Julian's absolutely spot on. It kind of covers a multitude of different functions, this particular so-called administration category, and therefore, there's a bit of a veil over it. So I like your challenge, and I think it's absolutely spot on that we should take another look at it when the team's ready through FIP.
Thank you. But it may be just a way of categorising the data as well. It might make it easier to. So I don't keep asking the same question.
Yeah, no, and actually, when we reviewed it last time, one of the things that there weren't a whole heap of pearls of wisdom that came out of it, but one of them was the sort of almost assertion that as we continue to automate and deliver on our digital agenda, that some of the more repetitive administrative tasks would start to be driven out, because that is the whole purpose of automation, let's face it. But that's only one relatively small solution to driving better administrative tasks, and this particular chart doesn't, it's not helpful in terms of getting to the details. So there's more we could do, and I think there's probably a bit more reporting that we could do to get under the skins of that.
Thank you very much, Naomi. If there's nothing else, can we move on to the performance report, Alex?
Yes, thank you. And again, I'll take as read, and you can see on the summary page the exceptions highlighted in blue, particularly for our improvement driver metrics. You'll note, as we have in previous boards, there is an upturn trend in self-harm, which it has focus and should be of some concern, but we know where it's happening and why it's happening. But those trends we would hope to begin to reverse soon. Continued focus on fire training and bringing back face-to-face fire training and ward evacuation now as we've come out of the second surge of the pandemic. So a continued focus around key safety metrics in here, and you can see quite obviously now on page 222 where our out of area placements are taking a significant spike in terms of demand on Prospect Park. And our requirement for beds at the moment, and that continues as we report here at the board today.
Thank you, Alex. I clearly looking at this, we've got some COVID effects coming through and various issues. Are there any areas where it's going the wrong way and they're going to red, where it is not effectively driven by COVID? Are we able to distill out those underlying features that, if you discount COVID, that we still have a sort of concern about, or is that too difficult at the moment?
It's a good and fair question. Debbie, can we just bring you in to particularly around falls and self-harm as an example?
Yes, so for falls, interesting enough, actually, if we look at the quality accounts, because that reflects the whole year, we've actually seen the same, we haven't seen a reduction, but we've seen the same average per 100,000 bed days as we saw in 1920. So whilst we haven't seen an overall reduction and we've got some peaks and troughs, there's a lot of work going on. I'm very optimistic we can get this back on track. What the community wards are looking at is some slightly different countermeasures. So the actions that were working pre-COVID and the sorts of patients we were seeing need a refresh, but they're onto that. With self-harm, it is driven by a small number of patients. I think it is a concern, but there's a lot of work going on around that at the moment to bring that down. So there isn't anything that we've got in here from a quality perspective that we haven't got work going on to try and reverse the current trends that are going in the wrong direction.
Could I ask one of those questions that they always ask on news programs of politicians? When are you going to solve the problem? So when I didn't mean it quite that bluntly, but what sort of timescale should the board be looking at this data again and thinking, actually, there's enough time gone by with the pandemic hopefully going away, or at least getting to very low levels, where we could start to see the data and interpret it more as a long-term trend? Is that a month, 3 months, 6 months, a year?
So I don't think we can say that the COVID is the impact entirely for self-harm. So self-harm that might have an element to it, but another element to it is the long lengths of stay of some of our patients who are particularly challenged from a self-harm perspective. So can I give you a month? No, I would certainly want us to look at, I wouldn't want us to say a month. You probably need to look at the next quarter, and there's other metrics that we also need to work on to help affect that change, like length of stay, particularly around self-harm and other factors. So it won't be simply just looking at the one metric, if that makes sense.
Understood. Chris, and then Julian.
Well, I'm so glad that you asked that question, Martin, because even I was getting fed up with the sound of my own voice, and I was literally about to ask it. And just picking up on your answer, Debbie, I suspect, my guess, my intuition is that the average length of stay in mental health is, whilst it may not be a direct COVID effect, it may have something to do with the fact that if we're offering in order to keep beds free, more community-based solutions at one end of the spectrum, then on average, the people who are being admitted are likely to stay longer. But just remind people that when we did the math for our bed capacity, we did model around 30. And if 46 is anything like right and anything like an ongoing number, then there's a 50% under bed. You know, we're 50% short of beds, which is only ever going to throw out of area placements. So it's just to remind people that if you like, the consequences of not being able to keep that number down over a period of time could be quite profound.
Thanks, Chris. Julian.
Yeah, thanks. There's a bit to work through, isn't there? I guess over the coming months. I guess to answer your question, Martin, I'd probably push back a bit and say on some of the metrics, of course, you know, we need some context because falls we were already, you know, the target we'd set, it wasn't the de minimis, it was a extremely stretched target that we set internally. So you probably wouldn't be interviewing us on the telly because you'd be going to somewhere with the high volumes, really. Whereas Chris's point about length of stay is a real worry because actually nationally that is a long length of stay. We know we've got a small number of beds, so that does create it. But there are some here probably where we've probably got a priority to fix sooner rather than others. So working through kind of where the priorities is, it will be maybe quite important. And also, I think, you know, us not blaming everything on COVID will be important because it's a bit wearing that some things are due to COVID, some things are not at all. And I think we need to retain that objectivity around it. And with that in mind, sometimes with falls and things like that, it would be useful occasionally to try and kind of place it in context of kind of national performance. So the bed day bit, you know, we're at the far end of length of stay, so we know that. Whereas falls, we're really good and looking to be kind of completely outstanding. And of course, you don't want to eliminate some of this stuff because probably you're going to start getting into restrictive practices that stop people being rehabilitated as well. So the other question is kind of where's a good number to kind of realistically get to, and where do we actually want to get to in this journey? We've got it for length of stay. Where do we want to get it to with the other things, really? So yeah, 2 thoughts on that, but a bit of work to do, I think.
Yeah, thanks so much. I say my question was not about particular ones. It was just about, you know, this going back, as it were, to the normal problems and challenges that we face, and trying to see when we expect that to revert from the COVID back to the sort of the norm, as it were, and then making sure we can have confidence in the data, not because the data is wrong, but just because the situation we're working in has settled down a bit. But thank you very much. Any other comments on the performance report? No. Can we just Naomi then on 8.2 FIP any update?
Yeah, no, thank you, Martin. I've really got nothing to add. That, you know, the quality of the conversation around the finances and the performance has picked up on the key points. I think the only thing I would add from a finance perspective is that of note is the capital performance over the last financial year. It was quite an ambitious programme of we were targeting a spend of over 8 million across you know, property and IT in the main. And in essence, we got there. We spent just shy of 8 million against a target of 8.3 million, which is impressive when you think about it through the lens. There was quite a lot of construction activity going on across that investment portfolio, and you know, we got it done. so again, you know, it's just another way of looking through, you know, through the lens of our good financial performance. That's it. You know, the go forward is about, as we've quite rightly identified, recognising that we have seen a bit of drift, particularly in the last quarter, around the key performance indicators that you know, attach to the True North performance scorecard. But as you've heard, you know, the team understands why, and the countermeasures are in play. And as you've quite rightly identified, Martin, some of that, not in large part, some of those key metrics attached to, you know, the disruption that has come about through COVID. So yeah, that's all I have to add. Thank you.
Thank you. Any questions for Naomi? Okay, can we then move on to item 9, the COVID-19 recovery plan? Catherine, are you there?
I am. Thank you very much.
Sorry, I haven't been able to see you on my screen, so it's over to you.
I'm here. I'm here. I'm going to take the report as read, but there's just a couple of things I'd like to highlight, if that's okay. All the services are now operational, and a number of the milestones from the March report have now been closed, so in a very positive position. But the two things I wanted to highlight, I took an action from the last trust board to present back some information on waiting list times and the impact that COVID had on recovery of services. So that works in hand. I've been working with David and the operations senior leadership team to have a sensible report that we can take to a number of different places. And that's in part concurrently, there was a conversation at the Recovery Programme Board about how we move this work into business as usual. So David and I and the operations senior leadership team have got both actions, and we're aiming to bring some proposals back to the June discursive, and the exec will do some work on those proposals beforehand. So hopefully you're assured that that's in hand and you will have the detail at the discursive in June. Happy to take any questions.
Thank you, Catherine. So just for clarity before I open it for questions, all our services are up and running. Okay. Sorry, it's an obvious question. I just wanted to ask the obvious question.
Yep.
Okay, Mark and then Chris.
Yeah, Catherine, I just wanted to mention that a number of us non-execs attended the governor's meeting last week, and during the governor's meeting we had what was almost a speed dating where we went into different rooms with different groups of the governors and they posed different questions. A number of staff governors were in each of those groups, and I was surprised by the consistency in each of the sessions that I was quizzed on. The recovery plan and the level of exhaustion was expressed from the staff in terms of a concern, was enough attention being given by senior management to the recovery of staff before the recovery of services, and that we had those in the right order. And so I felt that it would be remiss of me not to raise that today with you and the team, just to ensure that that balance, and I do appreciate it's a tough balance to achieve, that it was being struck.
That's really helpful feedback, actually, Mark. And I can see Alex has popped his hands up. We do have a people recovery strategy in place, so maybe there's something about how we make that more explicit and the messages share with staff about that. I don't, Alex, is that what you wanted to add to?
Yeah, Alex, if you come in and then Chris will come in again later.
Thank you. It's absolutely critical point, well-being of our staff, and Jane and Bridget Gamal are bringing forward our well-being and resilience plan, the next phase, to address the fatigue and the wear out that we know is there for people. And as we come out of this second wave and into a bit of space, we've got to bring that focus to get people's energy and ready for the recovery ongoing. So we plan to launch this programme early in June at our Trust Leaders and Managers Forum, and Mark, I know, is our wellbeing guardian on the board. You'll be involved in that and have seen the early drafts of the plan, and thank you for your input into that. But yeah, it's an absolute critical priority for us to get right now.
Just a thought then, Alex, I wonder, that's obviously coming to the board and I know it's going to fit. I wonder, because of the level of interest at the governor's meeting, whether at a future governor's meeting, Julie should include something there, because I'd be concerned that the non-staff governors may have been left with an impression that tainted their view, and it might be a good opportunity just to put the plan in front of those as well.
Helpful suggestion. Thank you, Mark. We'll do that.
Thank you, Alex. Thank you, Mark. Chris.
Really, just a continuation of that. Thanks to Mark for asking that question. I was also taken by how consistently it was a question asked of me, how we are balancing staff exhaustion and wait list and all those things. And the question that in particular the lead governor asked me was, what's the process and what data are the NEDs seeing to enable them, if you like, to hold the execs to account for a real process around this. And I waffled through, well, we're having a review at the May board, and then we're going into a June session where we're going to be talking about this, you know, following all the work that Alex just talked about. So, you know, clearly, and in support of what Mark said, it clearly is a hot topic, and one that the governors are looking for, if you like, a scientific approach around, you know, numbers where it's possible, rather than, you know, than anything looser than that.
Julian.
Yeah, I think it's more complicated than that. So there's quite a lot of services where demand's have gone down, Chris, but people are exhausted because their personal lives have been exhausted. And you know, the idea that you sort of compartmentalise, you know, what's gone on at home, or your bereavements, or if you've got colleagues in India at the moment, you know, you could well be out completely through the rinser because of that, but your service could still be 20% down. So actually, we could show you an array of stats that will show you actually quite a number of services where we've got activity down. But obviously there's context to this as well. So the data generally isn't showing a huge spike over and above pre-COVID levels. In fact, the last 18 months have shown overall across a range of services a kind of reduction in activity. But obviously there's reasons for that. It's a bit slower to do stuff. So again, I think probably in that conversation, we have to have a rounded conversation about well-being in the round. And also, I guess we also have to get the patient voice into this as well, if that's the balance, because there'll be some patients who feel they've waited an awful long time for stuff. So yeah, but I think it won't just be the data, Chris.
Yeah, thank you. I mean, we've got to be careful. We are diligent in our duty of care to the staff, aren't we? I mean, I recognise the balance we're talking about, but and you know, getting an idea, which I guess we've sort of triangulating this with various bits of data, just to make sure we haven't got perhaps particular areas where there's a big problem. I know the executive is sensitive to this, but I'd be unfortunate if we've missed an area because we weren't collecting the right data. Anyway, any other questions? Okay, Catherine, can we move on to your next report, SIP update?
Yeah, thank you very much. There are no major changes to highlight since the board received the last report, but it's probably just worth highlighting the exec team are also having a look at the format and content of this to make sure it's fit for purpose going forward. So we probably will be bringing back some proposed changes to this at some future date. Very happy to take any questions, but as I say, no significant changes since the last update.
Okay, thank you. I've got a few comments about the format to make it easier to read, but we'll take that outside the meeting. Any comments, questions? Everything seems to be broadly on track. Okay. Audit committee, Chris.
Yes, again, I'll take it as a read and understood paper unless you come back with questions. This was a normal meeting, bearing in mind that, you know, we have our 4 normal quarterly meetings and a 5th, which we'll be having at the back end of this month, where we sit in the shoes of the full board to do the due diligence around the post-audit financials. As of last year, if anybody who's not on audit committee wants to attend that, they should feel free, just have a word with Julie and get yourself on the invite list. I'll just sort of, you know, as I say, I'll take questions. We found that I found that over the years that the right thing to do is to make the March meeting, the March-April meeting, whenever it occurs, to be a little lighter in terms of agenda. Sort of, we perhaps don't have a sort of a thematic review, because we always have to leave some space for things that maybe started to arise in the sort of external audit, and there was nothing really like that. So just sort of skipping through some of the points, we've absolutely agreed that the next review of EUPD should be coterminous with the internal review, because why would we ask people to do the work more than once? And we've clarified that the audit committee's interest in QI was always should we say, light touch and focused on benefits delivery, such that we don't lose the confidence to be able to do something that we've, should we say, later decided was very successful on the risk, basically the risk that we took to invest. And absolutely, we don't need that to be an independent review. It was only ever required to be you know, sort of a holistic view of management. We did a thorough review of BAF. You probably noted the comments in here around single waivers, where we've had a bit of a spike, and I suspect that is a bit of a COVID effect. Also, we've been one person in procurement down for a while, and interestingly, because of our technology base, we've been able to recruit, albeit this person who's coming in is based in Leeds, works from Leeds, and we seldom in Bracknell. But there is confidence that we will get back to normal levels of service in that area. We also took a paper over the years. Every organisation on the planet accrues a level of, should we say, debtor that at some stage they have to just get round to saying, yeah, I'm never going to get that money, am I? And physically write it off the books, declaring it as an asset, you know, starts to be a little tedious. If it's, you know, long since been non-collectible. And so we so very helpfully, one of the trainees brought forward a paper on £75,000 worth of debt over, you know, that's basically accrued in part since about 2010. And we went through a process of making sure that all steps to collect have been undertaken. And when asked, both internal and external auditors supported the view that most, in fact, all trusts would be happy to be making this sort of adjustment over a 10-year period. It's very low by normal standards. The only real niggle was in the area of counter fraud, and it's something that I'll be taking up externally. Whilst we've got a very good internal counter fraud service, or externally provided, but if you like, embedded internal system, the powers that be have required that the declaration around counter fraud this year will be based on a new system that actually was only implemented on the 1st of April and will retrospectively apply it to our 31st of March position. And we had, should we say, anticipated additional things that we need to be doing, and we are already doing, but weren't doing at the end of March. So there are going to be a couple of slightly unusual reds on our return, but that is absolutely nothing to be concerned about. It's something that Alex and the team have got in answers to in place to take forward from the 1st of April. Just weren't doing in advance of that. And I'll take any questions that anybody might have.
Yes, thank you. Any questions, Chris? No? Very comprehensive briefing, Chris. Thanks very much. Annual report, Julian, it's got you down to say something on the agenda.
Sorry, Martin?
On the next item, 10.1 is the annual report, which I know we don't present at the public board meeting, but I don't know whether you wish to say anything or not.
No, it's there, obviously. Well, I'm going to credit Debbie for spotting an error on the staff survey results of a table, which really does show some due diligence. So thank you for going to that level, and we will correct that. Other than that, it is here as presented. It obviously is a look back over what has been an extraordinary year. And if there are any other points of inaccuracy, please let Julie know. Otherwise, this is the version that will get presented.
Okay, I think perhaps we can take that as a statement as it is. Thank you.
Julie, I've got a couple of things that I have spotted, and I will drop you an email on them. Okay.
Thank you.
Okay, anything else?
So, yeah, sorry, can I just ask a question? Has it been proofread or not?
Julie, can you?
It will be proofread. Yeah, with the auditors, with the auditors at the moment, and there'll be But if you do anybody spots anything, just let me know.
Okay, fine, that's great. There's a few little things.
Yeah, just send me an email. That would be great. Thank you.
Okay, anything else? Thanks so much. Councillor Governor's update. A couple of things. One is that the NEDs will know the online use of online for governors is sort of maturing. We've now got breakout rooms, which I think were a great success, seem to be well received by everyone. It's more of an intimate relationship, I think, with governors, smaller groups. There is also the issue which we need to consider is what we do in the longer term about staying online or face-to-face, but I think that's probably a discussion we'll have in the round. We've got 3 new governors joining, one from Slough, one from Wokingham, and one from the Young People's Dementia Society. I think I've got the title right, which is good. So I think I've got nothing else to add, but I'm happy to, whether my NED colleagues wish to add anything, but I think we've already raised the breakout rooms. Any questions you want to ask me about governors at the moment? Okay. Any other business? Anyone, please? No hands going up. Date of the next Public Trust Board meeting is the 13th of July, 2021. So there we are, the years passed by. Thank you very much, everyone. If we take, can we just reconvene at